really appreciate your attention, and it seems like the auditors didn't come, so that's good. We've got extra space for the people who are not enrolled. But feel free to get your food. Really very pleased to have Dr. Neeraj Sehgal here, Chief Medical Officer of Stanford Healthcare, as well as Senior Associate Dean at Stanford. And he has had a long, distinguished career at UCSF before we recruited him back. And I love to get a note from Dr. Sehgal. He said, "Oh, Peter Pompey was my preceptor in clinic." So, it's a small world here. Peter spoke last week. Wanted to give you guys updates. I know some people are asking about how I'm doing with chemo and so forth. I had my last cycle of chemo on Thursday. Feeling okay, a little nauseous, avoiding the Chipotle today because of that. Had a small sandwich earlier. But it's kind of interesting. Every cycle is a little different. Every cycle you have a little different symptoms, but it's not bad. I haven't had to take too much nausea medication. And one thing I learned is Zofran is very constipating. So I've prescribed Zofran many, many times, and it's constipating. So this is one thing my patients never complained about. And I'm like, now I know. And they're like, oh, yeah. All the oncologists are like, oh, yeah, Zofran's super constipating. And I'm so like, it's kind of this discouragement to take Zofran because you know the result later on. But wanted to start to see if anybody had any questions before we get started. Okay, so I'm going to do just a little whiteboard talk on 5 minutes on kind of my experience with healthcare access. So do you guys remember, I had about 5 to 6 weeks of a cough, right? Then I had a chest x-ray. Then I had a CT scan, then I had a bronch, and then I had my diagnosis, right? So this was this is, let's call this A, B imaging, C, and then diagnosis, okay? So this took, I don't know if you guys remember how long this took. So this took about a week. 7 days, right? So I found a study, of course. So if we start from first presentation A to imaging, okay, what was the time there? So that was for me, that was 5 to 6 weeks. So there's a study, 2022, they use natural language processing, look at the electronic medical record, look to see when the symptoms were mentioned, and when they got imaging. So any guesses as to how long that took for this population of several thousand in University of Washington? Take a guess. So this took me about 6 weeks, okay? Any guesses how long that would take? Big population? 6 months. 4 months? Okay. Not bad. So the median was 289 days. 289 days, right? So room for improvement. Room for improvement there. Okay, so from X-ray to diagnosis, so that took me 7 days. Yeah, Ross?
Is there a cause for that 289 days? Is that like who was delaying that? Do we know? Is it just
Yeah, so that's a good question, and that's so I uploaded 3 papers to Canvas. If you can't find them, let me know. I tried to label them with today's date. And we don't know. There's a lot of barriers, and I'll get to that in a minute. There are a lot of potential barriers for different people. In this particular study, they didn't really examine that per se about what was the delay and obstacles. So from B to D, so from imaging, so they kind of sort of lumped any imaging, X-ray and CT together, to diagnosis. What was that? How many days do you think that took? Any guesses? 30 days? Yeah, not bad. So it's about 43 days. So here, let me write this in. Oops. It's almost out anyway. So this is 43 days. And this is let's see, 6 times 7, say 42 days for me. So 289, and then for me, that was 42 days. Okay? So, and then there's another weird measure that they did, which was, the numbers seem not to add up, but I think this is because they had another point where it was referral or visit with the specialist, and that time to diagnosis was 72 days. So it's a little interesting, the imaging sort of, the time from imaging to diagnosis was shorter than the time from seeing a specialist, because frequently the specialist won't order imaging right away. So that was 72 days. But in my experience, in my case, I didn't put that on there because I sort of saw the specialists as I went along and sort of had informal care during there. So right, 42 versus 289, 7 days versus 43, right? I'm like the ideal case, right? I mean, other than maybe the 6 weeks, you could argue the 5 to 6 weeks, it could have gotten could have been shortened in my case. So why did I have such a short time? What are my characteristics that allowed me to have such, expedited care? What do you think? What was in my favor? So sort of the opposite of barrier. What was empowering me to get this fast care? So just name some things.
Connections to physicians.
So connections, so perfect. So connections, network, and you can even say, so like social support, right? Social support, right? That's all part of that, right? People always call, as you guys get your MDs and go and do your training, they're going to be calling you, right? Even if you're a dermatologist, they'll be like, my dad got hospitalized for a heart attack. Can you help me, right? Who do you know, right? It doesn't matter what your specialty is. They're going to call you and ask you. So that is absolutely true. What else? What else is in my favor?
The medical knowledge, so you know when a call needs to be
Perfect. So medical knowledge. So we call that also health literacy. So health literacy. Health literacy is kind of an awkward phrase, but that's what they use. Absolutely. I have second to an oncologist. I have pretty good health literacy, right? What else? Yep.
proximity to a hospital that has appropriate resources.
Fantastic. So location, right? I don't live in I grew up in Tennessee. I don't live in rural Tennessee. I live in a metropolitan area with access to an academic center. Perfect. What else?
Probably have insurance.
Insurance, absolutely. I got to pay for it, right? I'm not going to say, hey, I'm not going to go because I don't know how I'm going to pay for this. So insurance, and then also associated with that kind of financial resources. So even because these things, just having insurance doesn't guarantee necessarily everything is going to get paid for. You have co-pays, things may not get paid for. Dr. Sehgal was very nice. There was a weird thing going on with my CT scan and did some nice troubleshooting with me for that, so thank you for that. So it's complicated, right? This is super complicated in the United States, insurance. So you not only need insurance, you need some sort of financial resources for things that aren't covered by insurance. Yeah?
The time to not go to your work and
Sure, flexibility. So that's sort of part of that. So I had flexible time, right? I could take time off. Nobody really cared, right? If I could say, hey, I got to go to my appointment, nobody's going to ask me for that, and I'm not going to lose my job because of that. It's funny, I ran into Lloyd Minor on the way up, and so kind and nice. And yeah, Stanford is not that way, right? Everybody's very supportive. What else? There's lots more things here. Yep.
like means of getting to a doctor.
Transportation, absolutely, very important. So what do I speak? I speak English, right? Great. Fantastic. So these are kind of, things that are in my favor. You could reverse this and you could say, geez, I know patients who have none of these, right? Very easily. I saw a patient today who had none of these. Doesn't speak English, can't get there, can't get time off work, challenges with insurance, lives far away, lack of medical knowledge, doesn't know anybody, knows me, so asks me for who I would recommend. So you can see how our system in the US is very complicated. I happen to have check all of these boxes, right? And, luckily I was able to get very expedient care. You could argue this first part is mainly more of a medical issue, right? When do we order tests? When do we, are you going to order, you're not going to order imaging on everybody, right? If everybody we saw came in with back pain and we ordered imaging on, right, we'd probably there will be a social cost there and not cost-effective medicine. So this part you could argue, well, that's probably as good as you're going to get. Somebody comes with a cough, you're not going to really be able to shorten that time necessarily because there's a natural, let's see how things doing. Is it chronic? Did you respond to treatment, so forth and so on. So really thanks to Dr. Sehgal today to talk about barriers to access, healthcare access, affordability from his perspective as Chief Medical Officer of a very complicated, big medical system. So join me in welcoming Dr. Sehgal.
I'm going to stay seated for the moment. So first, I hope everyone echoes. So in full disclosure, Bryant happens to be my primary care doctor. And so when I learned about what Bryant was going through, I had an appointment that was getting scheduled, and Bryant will remember this. It was a video visit, and I found myself internally not wanting to do anything but just to check in on him. I'm like, I know this visit is for me, but I'm fine. How are you? I'm so grateful Bryant is creating this opportunity. I think all of you know how unique it is to all of us have our own lived experiences. Many of you have perhaps had them with your own interactions with the health system, your families. And so Bryant, just really grateful that you're continuing to create this space, because I could come with 30 PowerPoint slides or 60 and talk all around access, and nothing's going to be as meaningful as what I hope is the conversation and what you're learning from Bryant, and I hope what I'm able to kind of have a conversation with all of you about. I don't have any slides, by the way. So let me maybe briefly just share a bit of how I landed in this seat, and then I am actually going to have us think a little bit more in expanding what Bryant's already started, which is a little bit of like, what does good healthcare access actually look like? If we could define it, what's good at? What does it look when it's great or ideal? A little bit expanding on a framework of what are the key barriers? Why is it so hard? And we'll start broad, and then we'll give a couple. I'll share at least a couple specific nuances, and Bryant will join me in this. Is what's unique about cancer? Like, are there elements of the access problem that are a little bit unique for those that are being diagnosed, treated, and cared for, or have survived and actually have had cancer? And then I'm certainly happy to share a couple examples. Believe me, even at Stanford Healthcare, we have not solved this. Far from it. We've certainly done a number of things to try to help improve it, again, broadly in access, but also specifically for cancer. And so I'll share a few of those elements as well. But honestly, most of where I spend the time is actually a chance for us to interact, and actually for all of you to be able to ask questions and hear what your thoughts and your experiences and perspectives are. And I'm going to do that in a minute by actually having you do, I say, a quick pair share, so be prepared. You can eat your burrito while you're doing it, as long as you don't spit your burrito out at your classmate sitting next to you. So as Brian said, I did my clinical training here. So I grew up in the Midwest. I did my clinical training here. So Peter Pompey was my resident preceptor in clinic, which is why I was joking about that. And I trained here in the late 90s, and then I spent 17 years at UCSF and then returned. Most of my career, my clinical work is what we now call a hospitalist. So I primarily take care of patients who are in the inpatient setting. That field didn't exist when I was finishing my training. And the way I often describe it is that I always felt responsible for taking care of two patients: the patient in the bed in front of me and the building that patient was getting cared in. Because oftentimes the building was full of the same diagnostic therapeutic challenges of what we now call kind of system improvement and quality and safety. And so much of my career actually started up primarily in medical education, that a lot of the early work in helping educate and train the next generation, whether it was students and residents and fellows, in bringing a lens of doing systems improvement work and quality, so that you were both taking care of the patient in front of you, but also helping improve the systems around so we could have a bigger impact on larger groups of patients. I never had the career goal to be in the current roles I'm in. Like most things, the story sounds linear. It's never linear, as most of you already know and have learned from many of the people you're getting to interact with. But part of the evolution for me of getting involved in the health systems, as health systems were getting larger and more complex, as I often joke, what I loved about Stanford when I was here as a resident is it removed a professional ceiling I had self-imposed, and it reflected on the environment that was here, the people I got to interact with, those that invested in me and my energy, and learning to be a really amazing clinician and researcher and educator. And we were a really small hospital. We were like a small boutique hospital that served the local community. And part of why I came back 4 years ago is because we're such a different place now. We're still kind of medium-sized relative to our peers, but a lot of the complexity related to access we feel in both similar and different ways than, say, if I was sitting at Kaiser or if I was sitting at another much larger academic health system. And so as we think a little bit about the different structures and systems, those kind of play a role. So what I'm going to ask you to do, I'm going to give you just a couple minutes, and you can turn either to your neighbor, you can do this in 2s and 3s, and just have a quick conversation around what would ideal healthcare access look like? So if you were going to describe, this is what ideal healthcare access would look like, what would it be? And this could be based on your own experiences, family members, friends, just what you've read and heard about healthcare access. It's actually obviously a very big topic. Just take a couple minutes and just have a quick conversation. What does ideal healthcare access, what would it look like? Go.
And then it's like, okay.
It's really hard. All right, let's see if we can pull the conversation back as a group, getting to eavesdrop on a few conversations. So we'd love to hear from a handful of groups. Where did your conversation start? Where did it end? Things that were consistent, as each of you were sharing with each other. What does ideal healthcare access look like? Yes, please.
We started talking about the different factors to getting healthcare access, and we eventually came to the conclusion that all the factors are compounding. So if you have one risk factor, you're at a higher risk for other risk factors in terms of getting healthcare access.
Yeah, it's a really great observation. Yeah, please.
We were talking about the first barrier being the cost of insurance coverage and how some countries have successfully implemented universal healthcare, but how that also comes potentially longer wait times and distribution of resources in specific
Yeah, great. Others? Yeah, please.
You were talking about
Yeah. So almost a cultural element even more than a technical one. Yeah. Others? I feel like it's been this half of the room, so I will come to this half of the room because all of you were chatting as well. Yeah, please.
Yeah, we also talked a lot about cost,
Yeah.
and how that shouldn't be a barrier, like someone's financial status shouldn't be a barrier to them accessing care. We also talked about proximity. I'm from New Mexico, and so there's a really big problem there where there's only one level 4 trauma center in the entire state. And so people don't seek out care that they might need simply because it's so inconvenient.
Yeah. Probably heard the term medical deserts, which we talk about in a lot of the different places. Yeah.
Yeah. We also talked about trust and being willing to talk to your doctor.
Yeah.
And a lot of people will not go to the doctor. So all their issues will be fixed.
Really important point. We're going to come back to that one on the notion of trust. Yeah,
We
please.
also spoke about the safety and cleanliness of the sites, like the clinics and hospitals, and how that may vary in
Yeah.
different areas.
Yeah, great. Do we miss any topics that others brought up that haven't been brought up by your colleagues so far? Yeah, please.
We talked a little bit about access to health literacy.
Yeah.
And what that would look like. And everybody in the system has the same level of health literacy. And,
Yeah.
To Ross's point, it's talking a lot of prevention and preventive care, not just because it's literally nearby area for only hospitals, right? That's not going to be certain and help. Similarly, how do you
You can see why no one has solved the problem. All of you have nicely identified why it's complex. And part of why this exercise is really helpful, and I hope you'll keep it in mind as you, for those of you that are in medical and are going to go through, don't forget this conversation because you're going to live and see every part of it. Yourself, and patients you take care of, and family members. And it almost reflects the larger challenges in our healthcare environment. And I love the fact that a number of you are bringing up both very appropriately kind of system technical elements of the healthcare system, but you're also getting to really core elements of, as a society, how do we invest in health, not healthcare? As a society, what does it mean to look like trust? What does it mean to have a provider or a system that you actually are going to go to because you actually believe that your interests are going to be taken? Because I think we'd argue that if you don't have that trust, you can have as much access as you want, and it's going to make it very difficult to come in. So I love the fact that you're all thinking really broadly, that there are many, many facets to the challenges broadly with healthcare access. So I'm giving you one framework because actually your exercise with Bryant actually touched on a bunch of them. So this actually goes back, and someone will correct me if they actually Google it. I believe this goes back to a framework back in like the 1980s, that when initially this idea of talking about access, and I think the comment you made of, wow, it seems like when you have one barrier, you're at higher risk for the others, is in fact exactly why this framework was developed, to show the interdependencies between different facets of access. And so this is referred to as the 5 A's of access. And you can see you've actually touched almost all of them. So the notions of affordability, accessibility, availability, accommodation, and acceptability. And the other lens I would have all of us think a little bit about is we'll say, which of these elements have gotten better or worse? And we'll just say the last 5 years. We'll call it pandemic years, because I think there's many examples where in some ways we've made progress in some elements and we've actually made it much, much harder in others. And we'll come back to the 5 A's just to talk about them for a moment. But the secondary question is, what are the kind of key barriers? And I put green notations next to, again, large buckets that all of you had talked about. I think this big piece of connections is hard to characterize, but I think when you hear the stories, so often it's, I landed here because I reached out to so-and-so, whether they're in healthcare or not. And yes, there's a big part of that is frequently the entry point that lands with me. And a lot of times it is, as I'll talk about, like how to not so much make it that I'm the solution, because in reality, if I'm the solution and the bottleneck, then our system has failed. And so usually for me, it's I can serve as the individual conduit, as Brian kindly shared, to our system that helps address when these issues come up. And I'm really intentional about that when people say, because honestly, even in Brian's case, it wasn't so much that I fixed it. Mainly what I did was make a connection to the team I knew that helps patients navigate when they're having insurance coverage issues for, in this case, it was an imaging test, right? So a lot of what you'll hear me focus on is how do we build the right systems and people so that when key barriers are coming up, we have some ability to help patients, whomever they are, kind of navigate through it. So the connection piece, the location piece, so the example you were giving, I just can't emphasize enough that the lens of geography of if you're in an urban setting versus a rural setting, and I'll say that even that's getting blurred, and I'll give you the example locally, is one of our local counties, and as some of you may know, in California, we're really fortunate from a coverage perspective that largely most have access to health insurance, and a lot of our Medicaid plans are very county-based, so it's almost what we call like the Kaiser plans, where they're all managed Medi-Cal at the county level. So it allows a bit of coordination to help address many of these issues for patients, particularly that have Medicaid. But one of the elements that comes from a lot of that is we have one of our counties that had a single neurologist for their county health plan. That neurologist retired last year, and they've been unable to recruit another neurologist. So they've essentially lost. So I'm putting up here one thing that wasn't mentioned was workforce, like actual people, right? So when we go through each of these different elements, the 5 A's, you've kind of intersected these into here, right? So affordability, there's the affordability side that many of you are focused on, and Brian shared as some of it's about resources for the patient. Sometimes, increasingly, it's also the resources of the ability for the provider or the system to care for those patients. So again, in our region, from a primary care standpoint, as Bryant knows better than me, you know, we've lost a lot of primary care providers because they're going into what we call retainer practices, where essentially they don't take insurance and they provide a different care model. But by definition, that care model is only eligible to people who have the ability to be able to afford it, right? So it's solving one set of problems, but it's creating a different set of problems. So the affordability, just to have us think there's two sides to the affordability, and true for health systems as well, of how they manage the basics of where the dollars come from, how they use them, how the resources kind of get put together. And the accessibility, a number of you touched on, right? So some of that is about accessibility, about location and geography, but even around availability. One of the things we did a lot in the pandemic is, so at Stanford, prior to, as Bryant knows as well, prior to the pandemic, I hadn't arrived here yet, but prior to the pandemic, take a guess at what percentage of kind of clinic visits were done through now what we call video visits. Take a guess. What percentage of all of, so we currently do about 2.2 million ambulatory visits across kind of Stanford on the adult side. What percentage of those visits would you guess were video visits before the pandemic? Are you raising your hand? You're putting one up as 1%. Yeah. Yeah. So it was less than 2%. What would you guess that number is? What was that number the first 6 months of the pandemic? Yeah.
like 95 plus percent. And what do you think that number is today? Yeah, so not that. So we run around 35% that we've sustained. And by the way, that 35%, when you look at our peer academic health institutions, puts us at amongst the highest in the entire country. And then the question becomes why? The often easy answer or hypothesis, oh, we live in Silicon Valley, everyone's like tech connected. But it's actually not, it's part of that, but it's part of actually what has happened really intentionally, which is 35% is not spread across every area, right? So this gets a little bit to kind of ways we've tried to approach this here is back to the supply and demand, right? So the availability, how do we match what patients need versus what we have the ability to provide? And sometimes what we have the ability to provide is sometimes, do we have enough people and providers? And sometimes we have enough space for those patients to be seen. And so examples of like mental and behavioral health, which as all of you know, is a massive access problem nationally, locally, and regionally. 90+% of all of our mental behavioral health visits are video visits. Doesn't mean that there isn't a role for more in person, but it's actually helped us with a lot of the access issues. Whereas someone who's coming in with an urgent care issue that's going to need diagnostics, we want to make sure we have access for those patients to come in person. So the 35% is not spread evenly across specialties. In some specialties, it's 70, 80%. In others, it's 10, 15% very appropriately. But those are things we didn't know. Those are things we had to learn through the process to say, are we doing it safely? And our patients who are getting video visits, how many of them are actually then subsequently coming to see Bryant in person, even after the video visit, right? So I share it because even access through that lens of availability is still really new and novel. And we're still learning where do we do video visits safely and where do we do them otherwise. And then the other component that a number of you touched on, and I've written social drivers of health because to me this is one example of when a patient or a community is at risk for one, they're at risk for multiple. And so when we think about the social drivers of health, which many of you have touched on, whether it's through language proficiency, whether it's through feeling included or excluded, it gets to trust and gets to other elements, we know that you can have 3 or 4 of these, quote unquote, solved, but if you haven't thought through how to help address the social drivers of health, it's not going to matter, right? This gets it. I was telling Bryant the story of this morning. So I have family that is still in India, mostly pretty rural. And so my mom texted me this morning a little like what looks like a prescription pad chicken scratch of her brother who's 80, 85. And she's like, what do you make of this? I don't have any physicians in my family. And the health literacy is like so-so. And he's in a pretty small village in India. And the script, as far as I could tell, the handwriting was not great. Makes me realize for as much problems with the electronic health records, I don't miss the handwriting, myself included. And it essentially said what I thought was like right pleural effusion and said new, and then had a test order for an ultrasound. And as a joke, the price for that ultrasound was listed right next to it and the direction to the specialist. And so again, this is that international different ways people address access. You can still think of them through the 5 A's, but they're going to be thought of really differently. And I actually don't know, is it a good thing or a bad thing that my uncle is getting a prescription pad that says, here's the ultrasound, here's how much it's going to cost. And if he doesn't have the availability of resource to pay for that today, then we're back into this, what are the time periods between symptoms and diagnosis? And by the way, I don't know what he has. I'm concerned because he has a new pleural effusion and he's 85, and generally those are not good things. But I don't know because I can't actually even decipher what's been written on it. So I think as we think about the different 5 layers in the 5 A's, and all of you in your Bryant exercise kind of talk through the different components, this is why it's so complex, right? Does anyone identify a single solution here? Like this is the complexity. Yeah, please.
I understand that it has all this complexity and that Stanford has varying abilities to address aspects of these complexity. One question I have for you is how do you reconcile having not investing in resources into training people and into having maybe medical school or PA school? Because maybe that would help, like, from my perspective, bring more doctors and you know, if we can educate more people, they can go into more of the rural areas and they can provide more services. And it seems like Stanford is at an especially good place to be able to educate more people and solve, you know, a large part of this. Yet their acceptance rate of medical school, I'm not applying, is, I can assume, pretty low.
Yeah.
Right?
Should we go get Dean Miner and see if he's able to answer? So let me broaden you because your question's a really, really important one, and it gets a bit to kind of the workforce piece you're describing. So let me try to answer it in two ways, including I can't give you a specific answer as to the strategy for the Stanford Medical School, but I'll give you an example for the state of California. So workforce here we're talking about kind of physicians, but you're appropriately broadening it to think about other clinicians, whether it's advanced practice providers, nursing workforce, that a lot of what you've seen happen nationally, and the pandemic just accelerated this, was a lot of places had physical spaces and elements and just didn't have people, including in hospitals. Couldn't hire, couldn't retain, couldn't keep nurses. We're fortunate, we did not have that particular problem here. From a workforce standpoint, I guess there's two ways to think about it. One is state of California has actually done this study looking at the population, the demographics of California, how they might change over the next 20 to 30 years, and where do investments need to be made. So again, from the state of California, the biggest levers they have are where you have the 5 medical schools that are state-oriented, which are the 5 University of California systems. And having come from one of them, that was a lot of what allowed some of the growth of the different programs, both from a school of nursing, school of dentistry, school of pharmacy, school of medicine, advanced practice areas, and others. So the state schools are very tied to the strategy of at the state level because the resources obviously kind of help support them in both directions. The other question you might ask is if you look at graduates of medical schools from the US, are we matching the supply and demand of what's needed, right? So this is the classic description of, a number of you touched on prevention, where when you look at our country compared to other countries, do we invest enough in prevention, which often is through people like Bryant, primary care physicians, right? So that our relative primary care physician workforce is not nearly as wide and depth as many other countries, and a smaller group of specialists, whereas we have in some cases almost inverted pyramid of that in many areas, right? So that's not about who we're bringing into medical school, that's what are the way we're creating and matching people into where the needs are. So the other very good example you gave is, again, I'll use the UC system. They opened a brand new medical school in Merced recently. And part of why they did that was for the very reason your question's getting at, is they recognized a big gap in physicians in a community that needs them. Let's put a medical school there. Let's try to recruit people from the community who want to be trained and then want to work in that community. So there's a lot of that happening in multiple parts of the country. It doesn't address the specialty generalist component. It doesn't address the fact that the most competitive residency programs are because they're the fewest number of slots, but are they really matched to where the greatest need are? That's a much larger policy kind of conversation. And I wish I had a better answer for you for kind of the Stanford strategy in terms of the School of Medicine and others. Stanford, like every other place, plays a role in our larger healthcare ecosystem. And I think all of you, I hope you're here, if you're here as medical students, because you realize you're here to have an amazing clinical training experience, but also because all of you already have accomplished something that is going to allow you to also be the leaders of tomorrow. And maybe that's in research, maybe it's in education, maybe it's in innovation, maybe it's because we live in Silicon Valley and you're going to be helping start new products. So I think that's the thinking about what each part of the ecosystem does to help address the workforce piece. And there's lots of policy thinking about how we do that, state and federal. Let me pause again, just here. I'd love to hear other questions and reactions. Again, this is really just to give you a labeled framework because all of you have touched on the 5 A's. And the barriers, there's lots of interdependence too. I will come back before in our last 5 minutes, just give you a couple examples specific to cancer of areas where we've tried to address some of this. Again, not perfectly, but actually recent examples. But before I make that transition, let me just see if there are other questions or just reflections or observations on the complexity of access. Please.
Something that we talked about was taking like ambulances, for example, how they're so expensive, but we're encouraged to like dial 911 when there's an emergency. But then it comes with a huge cost, and that prevents like a lot of people from actually like dialing 911 and getting the care that they need. What are your thoughts on that?
So one, I think the answer to that question, this is a great place where sometimes data can be helpful, because as you know, one of the markers nationally of ambulance time response, and they've studied this from different cities, where that response time for ambulance actually has huge impact on outcomes for things like stroke and heart attacks and others. I don't know if I have an elegant response to the idea, because I think the role of EMTs, I'd say make less about ambulances, but more about the professional services that EMTs have continued to bring. Remember, it's not that old. I mean, EMTs really started in the last 60 years or so. I mean, before you could do nothing in the ambulance before what has evolved in terms of care. The example I'll give you, I'll go back to India, because I learned about this group when I was returned here through colleagues, is during the pandemic, they actually, an ambulance company there redeployed all their ambulances actually to provide access in rural areas. Not to bring people back to where this town was, but actually to take care kind of out. So where your question goes to me is it's another part of the healthcare ecosystem, and are we optimizing what we could be doing, not so much with the physical ambulances, but the care that's provided through the ambulance care. Because I don't know if I know enough about why people call 911 and why they don't. Is it for some of the same different factors, and is the solution more ambulances, or is the solution a different solution? That I can't answer for you, but I do think your question around can ambulances, the expertise that EMTs bring, should we be thinking about them more broadly as ways to provide care in places that have less access? Absolutely.
And that touches on access to primary care. If you have a good relationship with your primary care doctor, perhaps you don't call, or if you have easy access or somebody answers the phone, like we have a clinical advice service 24 hours, 24/7 at Stanford, and they didn't have that when I started at Stanford. So if you call, no matter what, and you say, I need to talk to a nurse, they'll get you, you'll be able to speak to a nurse who can help you with that decision, because it's confusing, very confusing.
And Brian's giving an example of one of the things I was going to share, which is a good example. As the systems grow larger, this tension of, do you call the practice? So if I have an issue, do I just pick up the phone 24/7 and call Brian's office and ask for support? But part of what Stanford's invested in is a centralized clinical advice center. And it's based out in Newark. I've gone there several times, and usually what I do when I go there is I spend about an hour and a half, and I just listen in on phone calls with the team that's doing it. I don't know if you've ever been out to Newark. It's amazing. They sit there with 3 screens, and I've listened. They're organized in 3 areas of the types of phone calls. If they're like really generic, basic, how do I get a primary care doctor? They get routed to one group of people who are kind of more early in the clinical advice, versus I've been seen by 3 specialists. I need this appointment and this diagnostic, gets routed to somebody who's got more and higher levels of training. So it's one of the solutions that we've created, which is an investment to allow patients access to at least help them troubleshoot and problem solve where they need to go. On the cancer side, as all of you know, and as you've probably learned even through this experience with Bryant, is I think 2024, and I'm not the cancer specialist, will be the first year we hit 2 million new cases of cancer. And when you look at the prevalence of cancer, while many diseases, fortunately, are getting much better treatments, people are surviving, living longer with it, we're also getting a massive continued growth of number of cases. So when Stanford Medicine, one of the large initiatives over the next 5 and 10 years is actually really doubling down on cancer care in particular, including the idea and design and vision to build a cancer kind of specific campus, partly because cancer, as Brian's helping teach you, has gotten so complex in the diagnostics, the therapeutics, the specialization. And so an example here that Brian's certainly aware of is, even in the last year, our cancer center kind of service has actually built a diagnostics clinic. Because if you were a primary care doctor, and let's say you were in this process, that you had a patient, chest x-ray shows something concerning, what used to happen 15 years ago is they'd get admitted to the hospital, and they'd be there for a week getting all the different diagnostic therapeutic tests before they had a diagnosis. Maybe the therapy would start while they were still in the hospital, be a 3-week hospitalization. And so much of cancer care now, I've watched this in my own practice the last 25 years in the hospital, things we used to take care of in the hospital almost rarely see the hospital. Now when they come in the hospital, it's from all the unfortunate complications and the progression of the disease. Most at this stage, as Brian's already demonstrated to you, you never even see the inside of a hospital. And so the challenge that it creates is, how do you get this time window to become a little more efficient? Because as Brian's alluded to, I always say this, for many patients, the hardest part is the waiting part. It's the uncertainty. It's the waiting to know what it is, what it's not, what it's going to mean. So we've set up a diagnostic clinic specifically for patients who don't yet have a diagnosis, but a high suspicion for. And it allows that centralized clinic to basically help shepherd patients through the process. What we haven't solved for are some of the other elements that all of you have brought up, some of the social drivers of health, some of the insurance access that, again, the country we live in and the state we live in, where you are insured has a huge impact on your health outcomes. Believe me, from a policy perspective, I wish that was not the case, but that is the case. And so, as you're going out and voting and you're hearing and learning about what's happening in legislation, this is the impact you kind of see in different ways. Let me pause again and see. We've got, I think, 2 minutes left. Let me just see if there are other questions folks have, or as you're hearing about the challenges of access, both in cancer and otherwise. The other part of cancer that I'll also point out that our cancer team thinks a lot about is we now have
8 or 9 different sites across the Bay Area. So again, this idea of location, how do we make the access easier, because so much of cancer has gotten so specialized, and as Brian also knows well, we talk a lot about clinical trials, and I and many of the folks that specialize in cancer often say clinical trials are not about research, clinical trials are clinical care. And we know what happens as patients get opportunities to participate in clinical trials is the care allows us to continue evolving and getting better. Clinical trials are not representative of our entire population and community. It's one of the biggest barriers. And so when we're trying to use evidence to say which patients are going to benefit with which cancer-specific therapy, our studies need to also match the very patients we're taking care of. And we have lots of work to do there to make that a bigger realization as well. So my hope here was to give you a very broad just framework, as many of you frankly already had highlighted. Kind of the 5 A's is just a framework to think about the access elements, and then recognize cancer has some unique flavors of that, but I think you'd agree, all of the things that affect access in cancer affect access more broadly. We could have had the same discussion about mental and behavioral health and had a similar conversation with slightly different nuances of what availability and accessibility look like. But again, let me pause. We've got about a minute or two left. Let me just see if there are other final thoughts, final questions, reflections about access. Yeah, please.
Does Stanford have like a 5 A's dashboard? Where
Yeah, really good question.
we're trying to figure out how are we doing on affordability, how are we doing it? Does that exist, or
Yeah.
how does the
It's a really good question. So this is the, how do we as an organization assess how we're doing? And then where do we have opportunities? So we have, I'll describe 2 structures. So we have one large access leadership team. And so that access leadership team meets literally almost every week. And they do have kind of data dashboards. Some of them are not probably as mature enough to be able to adequately capture some of what the barriers are. But for example, now the state of California has required all hospitals to assess every patient for social drivers of health. So we are now doing that in ways we weren't 6 months ago. So now it allows us to actually say, simple measures. How long does it take to get a clinic appointment? Is it equally easy or equally hard depending on your insurance? Is it equally easy, equally hard depending on whether English is your primary language? And now we can start asking those same questions for social drivers of health. So I think we're maturing to be able to better understand, particularly down at the service level, right? At the organization level, you only get a certain view. What I'm more interested in, back to the video of example, is where are we doing things really well and why? And where can we learn and spread those? And the other example I'll give to Brian's clinical advice centers, we also have something called network access optimization. So this idea of, for patients who, no matter where they are, the goal is to provide them better care, the right care at the right time in the right place, that has to be closer to where they are. And so a lot of these efforts are trying to say, as we've become larger and we're more in the region, how do we make sure that someone who lives in Pleasanton doesn't need to drive to Palo Alto if we can provide care with our teams closer to Pleasanton? So I think a lot of those central structures are trying to do a better job of that. It's a really important question. Any other last thoughts? Yeah, please.
I'm just wondering if you can define what affordability means with cancer care, because to me, they don't seem synonymous at all, especially when you think about insurance.
Yeah. Yeah, Brian and I were just joking about the medication Zofran, which he was joking about it being constipating, because we were reflecting that almost, probably maybe 8 years ago, Zofran as a medication, you couldn't prescribe it to anybody unless they had a cancer diagnosis, and even then, you could only prescribe like 6 pills a month. So your question is getting at this issue for cancer, where a lot of the diagnostic therapeutic, a lot of the R&D, for lack of a better term, that's gone into helping build new therapeutics has a cost associated with it. And so where does that cost get borne? Is it borne by the system? Does it get borne by the payers and reimbursement? And I think it depends, right? This is part of the challenge of why many of you reflected on insurance plays a really big role in access, and it doesn't make it equitable, right? So this gets back to like, who are the providers in the plan? What's covered, what's not covered? And I think there's often a lot of focus on people who are uninsured. I actually worry a lot more for people who are underinsured. And what I mean by underinsured is they have some insurance, but it's not making it affordable for them, right? So insurance by definition does not, to your point, solve affordability. Insurance is one vehicle to create access, but affordability is so much broader in ways that we need to grapple through, particularly in cancer, because the cost of cancer care is going to grow as the illnesses become more prevalent. So again, we haven't solved it, but I think your question is a really important one.
Well, thank you so much, Dr. Sehgal. Fantastic. I'll leave you with one number. The medication I'm on, the targeted therapy Tagrisso, osimertinib, the list price, did I talk about this? Do you know what the list price is for 1 year of treatment? It's an oral med, I take it every day, gives me horrible acne. $200,000. $200,000 for 1 year of osimertinib, which I rely on to keep me alive.
Is that with insurance?
That's if you had to pay out of pocket. Yeah. It's very opaque what insurance actually pays. We don't know that. Yeah.
which things they cover. So the last example around the drug therapy, this is not something we've done in our country, but there are other countries that actually have a centralized board that decide what things are covered and what are not based purely on cost. Again, there's no judgment to that. That's just different approaches on how to manage stewardship of it. And Brian's giving a really visible one, which is back to your question on how do we make it.
Well, thank you so much. Really appreciate it.
Thanks, everybody.
We do have some extra burritos and chips. Feel free to take.